the first thing is to obtain a past medical history and surgical history. Make sure you're safe enough to have a cosmetic elective procedure. Is the risk worth the reward? Will this procedure meet your goals, okay, and satisfy your cosmetic goals? All of these things are factors that we're going to look at in depth when you come in for a visit. Physical exam will include several measurements, as well as assessment of the skin quality and the breast tissue itself. And that will help direct or dictate what procedures are best for you. So for a breast lift, we have to address two main issues. One, excess skin and a potentially low nipple position, and two is the breast tissue that's slid off the chest. It's not back up on the chest where we'd like it to be. So let's go ahead and draw this. So that is not an uncommon breast to see. We'll do another one, not as good, that's okay. I'll wait to draw on that side. So one of the things that most common techniques that I use is a wise pattern for the skin. And this is also called an anchor scar. Okay, and this is for the skin. So that's the first thing we need to address, and that'll actually help move the nipple up as well. And then what are we doing on the inside? So this is where we get to a what I call, or we call, superomedial pedicle, and that's going to provide blood flow to the nipple and also help, and this is going to be, I will say it with auto augmentation. Okay, flap. And so this is for the breast. So over here with our nipple, it's been stretched, it's hanging lower, the breast tissue is drooped off the chest wall. This angle here is kind of elongated. So one of the things we want to do is we want to get the nipple back up on the mound. And go around the nipple and areola here. And then with excess skin of the lower pole of the breast, we would get rid of that extra skin, okay? And so this is kind of what you should see it as. Sorry, this is not the best writing surface here. Now when I do this, so that mimics where the skin will be removed. I will actually also cut into the areola, the pigmented skin around the nipple, and I'm going to make that smaller too. In fact, I make it a little bit too small, artificially small. And the reason is when we move this nipple and areola back up here, we put it under tension when we tighten the skin and breast tissue. That will put more tension on the areola, and you're going to have what happened the first time, which is the areola is going to slowly stretch over time. Okay, that's what the areola does. So what we're going to do here is we're going to bring this point and this point right here back down around, and it's going to meet in the middle. Okay, it's going to, and this is going to be a straight line. This is going to make kind of a keyhole, which the nipple will move up into. Okay, so what that leaves to us with is a new incision around the areola, a vertical scar, and then a variable length side to side. If it's a smaller lift, you can make this shorter, okay? If it's a lot of skin that needs to be taken off, then that can be longer, okay? And these are those little points, okay, that were here and here. All right, so that looks like an anchor, also looks like an upside down T, so a T scar, that's where that comes from. Perfect. Now, that's how we address the extra skin and kind of elevating the nipple back up. But we have to also get the breast tissue back up on the chest. So how do we do that? Well, that's this part here, okay? So I'm gonna draw this up here, even though I know this is not where this goes, okay? It just helps illustrate a point here, so. And let's pick red. Great. So what we have here is what's going on the inside. So you can think of it as cleaving the breast in two. I know that sounds dramatic, but what that is just below where the nipple and areola is, down to the chest wall, would be an incision through the breast tissue. Okay, and it leaves kind of like a lower 2/5 and upper 3/5 of the breast. Okay, so most of the breast tissue will still be up above, okay, but some we will keep below. The nipple's going to stay attached from a blood supply that's coming in from upper inner, so superior and medial. And so that's somewhere like this. Okay. Let's go back to black. Perfect. So that's going to supply blood to our nipple and areola, and we need blood supply because any tissue without blood supply is dead tissue. Okay. So the nipple will be able to move up and rotate up into this new position. This lower portion, okay, is analogous to an inferior pedicle, okay, and that is going to provide additional bulk, and it's going to be advanced here. Okay, and I put little hash marks, okay, which will end up being underneath our new, underneath our new nipple and areola, okay, and it's going to provide bulk of this lower pole of the breast. Okay, this green stuff is highly variable. I try and keep as much of the breast tissue as I can in a breast lift. If this were a breast reduction, this would be an area where I would take that breast tissue away to reduce the weight of the breast. So here we go. This is going to be that flap, okay, auto augmentation flap. Auto just means it's your own. Augment obviously is add volume, and it's a flap of tissue with blood supply. Now, this is going to function similar to an implant, being located behind the nipple and areola and providing bulk. However, it does not function exactly like an implant, okay? So let's draw this. So this will tends to produce a breast shape that's more of a, more of a teardrop, okay? And here we go, all right? Versus a full profile or extra full profile implant, okay? Which is gonna create this right here, which is superior pole fullness, okay? So we don't really get that long-term with a breast lift. You can supplement this with fat grafting, okay, and that can improve the contour a little bit and also provide a little bit of volume. And I find many patients are happy with that approach in order to avoid an implant. Perfect. Now, things to consider with this technique. One, the initial shape that you're going to get is actually going to look kind of like an implant, okay, or an upside down breast, okay. So the top part may be full because it's swollen, okay, and that flap is artificially high and swollen, it will settle down. Gravity will then, when swelling goes down, gravity starts pulling back that flap down again. That fullness is going to actually settle back down lower, okay? And that will start giving us our normal brush shape. Sorry, it's kind of hard to write on this thing. Okay. Now, the other thing to notice is the nipple position immediately after surgery, okay? It's gonna look low, all right? It'll look artificially low, artificially small. It may be even pointing downwards, okay? That is all par for the course. This tends to be also flatter because that's where we removed all that extra skin. That skin's gonna stretch again also when this flap settles back down. And so when that happens, perfect, nipple's in a great position. Now, if we were to mistakenly place the nipple here, okay, and I will do this in red. So if we were to put it at the time of surgery at the apex of that breast mound, that's gonna look good until gravity wins, that flap settles back down, and now we have, a nipple that's too high or looking at the sun, okay? We call it a stargazer. Okay, so that's, a frustrating portion of the recovery for a breast lift, but once you're aware of it, you know that it's gonna settle out, people are reassured. Now that can actually take upwards of 4 to 6 months, okay? Now, not in everyone, okay? That's the outlier. In most patients, it's settled out before then, okay? Usually kind of 3 to 4 months once the swelling has gone down. But 4 to 6 months, if you're trying to get this surgery done in a specific time window, and you absolutely want to make sure that your breast lift is looking good, particularly out of clothing, then 6 months would probably be the safest bet. Although for most patients, earlier than that should be fine. All right, so let's talk about common risks, okay? The common risks here are, I kind of go with short-term and long-term. So let's do this down here actually, because I'm gonna run out of space. Perfect, so immediate risks. Immediate risks include bleeding, okay? With bleeding, this can lead to what we call hematoma, which is just a collection of blood, and if it keeps collecting, it can be an expanding hematoma, which may compromise the blood flow to the tissues. That may require a return trip to the OR. Return to OR, okay? This is rare, okay? The other issue is blood flow to the nipple. All right, so as I drew up here we go, right? So this blood supply comes into the nipple, and it needs to provide both blood out to the nipple and drainage away, and that's the venous outflow. And either side of that could become compromised, either not enough blood flow out or not enough blood flow draining away, okay? If either part of that flow system breaks down, you can wind up with no flow, okay? And any tissue without blood flow is dead tissue. So blood flow to the nipple is an issue, or can be. It's pretty rare for this procedure, more so than a breast reduction. However, if there is compromise of blood flow, there are certain things that I can do in the OR to try and improve it. If I cannot, there is an exceptionally low risk, but not zero, that you could compromise the blood flow to the nipple and need to do a free nipple graft, okay? That just involves having to actually physically remove the nipple and areola off of your body and then sutured on like a graft, a skin graft. And when that happens, we've cut away the nerves and milk ducts. So, major consequences of a free nipple graft are, excuse me, no sensation to that nipple and inability to breastfeed. Okay, but again, like I said, this is very rare. In fact, I have not had to do this for a breast lift itself, although I have had to do that for a breast reduction. Typically, those are very large breast reductions. But again, it's a theoretical risk, so we should probably cover it because it is significant. Those are significant consequences. Perfect. So now we get to intermediate risks. So intermediate, just meaning timing from surgery. Okay. And this has to do mostly with healing. Okay, so this is your wound healing here. And infection and seroma. Perfect. So, wound healing. The most common area for wound healing problems is actually right here, okay? And that's called the T-point, or T-junction, or there are several names. But I like T-point because this looks like a T, okay? T also stands for tension, okay? Now, what does tension do? Tension decreases blood flow. So, with less blood flow, any tissue without blood flow is dead tissue. You can wind up with a small area of what we call skin necrosis. Just means a small area turns into a scab, okay? It's usually less than about 1 centimeter squared, okay? And that's not everybody. That's I would say probably about a third of patients will wind up with one of these on one side. It's no big deal. Dry dressings, it'll heal. Okay, sometimes it heals with a little bit widened scar, but that is typically hidden, as you'll see in these photos later, as the breast kind of hangs over that scarred area. Infection, again, very rare for breast lift, a little more common for breast reduction. Seromas, same thing. We're not, typically the breasts aren't so large like a breast reduction where there's a large area of inflammation in surgical space, because that's what leads to seromas. So this is very uncommon also, but again, theoretical risk. And we have long-term, and I always say consequences and not complications, okay? So not complications. And the reason for this is we know these things are going to happen, all right? And the big one here, people always mention the scars, okay? And for most patients, the scars are a good balance, a good bargain for the improved contour and feel of the breast. But they can be distressing. So scars can widen and stretch over time, okay? If you're predisposed to this, they can even form what we call hypertrophic. Oop, I do know how to spell hypertrophic. Or keloid even scars, okay? So keloid scars are the bad ones. Those are typically family history of keloid scarring. And so if that's you, you may want to really consider just not doing the procedure, okay? Keloid scarring specifically. Many people think they have a keloid scar and actually they just have a hypertrophic scar. And this can be treated with steroid injections. Okay. So it's mostly just kind of distressing. All right, perfect. Scars take about 8 to 12 months to mature. So you really won't know what the scars are going to look like until you get to at least 12 months, okay? So keep that in mind. Nipple sensation, okay? It's important. For some women, it's much more important than others. So I don't poo-poo that. I think that is very important. However, we have to appreciate that there is a risk for permanent loss of sensation. So I say, again, about a third of my patients will wind up with decreased sensation, maybe not no sensation, but decreased sensation that's permanent. And it's usually in one nipple and not both, okay? It's very rare to have both nipples out, okay? Breastfeeding, I can't guarantee that you'd be able to breastfeed after surgery, okay? Usually women who are interested in breast lifts have already had children and usually at that point ready to have their surgery, so it has some longevity, okay? If you're still planning on a pregnancy soon, then that's one reason you may want to consider delaying your breast lift until after you've done that, okay? Otherwise, your money's not going to go very far and the longevity of your result. So, perfect. And finally here is impermanence, okay? That means that the result that you see is not going to last your lifetime, all right? And the reason for that is aging is a biologic process, and it's complex. Okay, yes, there are some environmental stimuli that will aid in aging, and so one of those is gravity, okay? So I recommend bra support for life. And I even recommend it at night. We can talk more about that another time. And then avoiding things that prematurely age the skin, okay? And that includes tanning and smoking, okay? So avoid these things and wear bra support. And that's gonna do about as good as you can for improving the longevity of your breast lift. Avoid massive changes in weight or pregnancies, because that's going to stretch the skin also. Okay, so weight change or pregnancy. Okay, perfect. But still, aging is a biologic process. I can't fix that with a scalpel. So the breast undergoes normal aging, and this is largely hormonal with some control by your genetics and how those hormones affect expression from your genes. So the breast tissue itself will typically convert more to a fatty sort of consistency, whereas when you're younger, it's more glandular, which is firmer and provides more consistency for shape and fullness. And then when it gets converted to more of a fatty type of breast tissue, that's when you get drooping, okay, and deflation. Perfect. So those are the main complications and considerations for a breast lift. Next, I'd like to briefly talk about recovery recommendations for breast lift surgery. So 4 weeks, okay? In that 4 weeks, I recommend a bra 24/7, okay? I recommend no intense exercise, okay? Okay. I also, for most patients, probably no sleeping on your sides, because typically it's uncomfortable with swelling. And avoid big trips, what I call big travel, okay, where you may not have access to medical care. And that's mostly just because of seromas, okay. You could also add here, avoid a big engagement, because if we do have a complication, we may have to address it before your big soiree. Okay, so perfect. In the first 1 to 2 weeks, we're going to have no lifting. Okay, I say that, reaching and pulling. Okay, so no lifting. Typically, that's more than 20 pounds in the first 2 weeks, and avoid reaching and pulling with your arms because that's going to put tension on the swollen breast. 3 to 4 weeks, you can start doing some lifting, and I usually say that's up to about 45 pounds, and that's adequate for most people's work. Okay, and then you can start reaching and pulling with your arms. All right, so these are restrictions for work. Okay, wherever you fall in, if you have a significant lifting requirement, then you may have to wait 1 to 2 weeks before you can go back to work. If it's more than 45 pounds, 100 pounds, which would be impressive, then you may need to wait after 4 weeks. Okay, so that is typical recovery. We have, as I mentioned before, 3 to 4 months is most common for the shape. Okay, but 4 to 6 is kind of the outlier. Okay, and then the scars are going to be 8 to 12 months. Most of your swelling should be around 2 months. Okay, and it's at this 2-month mark, you can go out and buy bulk bras. Okay, and you can wear an underwire if you want. Usually it's fine at that point. And once your volume is set, similar to about 2 months, the breasts change volume only slightly after that point, so it's okay to go ahead and buy your new bras. All right, but the shape out of clothing still takes a little more time. All right, perfect. So I think that about covers it for the recovery and expectations. If you have any questions, feel free to reach out to us at alamoplasticsurgery.com, and we'd be happy to answer them.